Oh, okay, it's going now.
Okay, perfect. Yes.
All right. Go ahead, Rebecca.
Good morning, everyone. I think we have people joining. I see several people have their videos off and are muted. My screen doesn't show any pictures. So John, can you see our participants?
Yes.
You can. Okay. So we'll give it a minute.
I think most of them have their
Well,
video off, and if they wish to turn it on, it looks like they have the capability to.
Yeah.
But that'll be up to them.
All right. So welcome, everyone. We're going to give it a minute or so to see if anybody else joins. My name is Rebecca. I'm a CRB field manager. And my colleague, John Nichols, is here, also a CRB field manager. And this is the PCIT webinar, live webinar. I'm going to briefly introduce our speaker, and then I will turn it over to her. So Alejandra Moreno is a licensed professional counselor. She is a clinical supervisor for the Children's Outpatient Services team at Jackson County Mental Health in Medford. She has been working with young children and families for almost 30 years. She is a specialist in infant mental health. And she is also certified by PCIT International as a PCIT therapist and as a level 2 regional trainer. So I would like to turn it over to Alejandra, and thank you so much for being here to share your knowledge with us. Thank you.
Thank you. Thank you, Rebecca, for that introduction. Thank you, everyone, for having me here today, sharing with you a little bit of what I do and what I love doing. I'm going to share my screen. Let me start this. Oh, okay. Let's see. I don't think I can do that. Okay. Let me go ahead and share my screen first. Okay. Okay. Can you guys see my screen? Can you see the presentation? Yes. Okay.
Yes.
Perfect. All right. So let me just move. I'm going to say, let me just move you guys out of the presentation, out of the field here, the gallery view. Okay, perfect. All right, so today I'm going to be talking about PCIT, Parent-Child Interaction Therapy. This is something that I have been doing for about 15 years. I started, actually, I am one of the 2 clinicians that introduced PCIT in Oregon in 2004. With a very small grant from the Oregon Health Authority to do something innovative and different in terms of children's services. And because we got such amazing results and outcomes, the state decided to fund more sites in training in PCIT. So I continued my training. I became a certified PCIT therapist, and then I became a level 1 trainer. Level 1 means in-house, meaning you can only train your coworkers that work in the same agency with you. And then I continued my training, and several years ago, I became the first regional trainer for the state of Oregon. So I now trained all over Oregon. I have trained close to 100 clinicians in the state of Oregon in PCIT. So thank you for giving me the opportunity to share this with you. I have some objectives for our presentation. Hopefully by the end of the presentation, you will be able to understand and describe what is PCIT and who it is for, understand what it is, why it is a treatment of choice for children with a history of trauma, and identify the benefits of doing PCIT with children in foster care. Just a quick disclosure, I am a member of the PCIT International Training Task Force. However, I do not have conflicts of interest to disclose, and I do not receive any commercial funding by any commercial entities that may be mentioned in this presentation. Just a quick acknowledgement to my trainer, mentor, and friend, Cheryl McNeil, Dr. Cheryl McNeil from the University of West Virginia. She is the author of the PCIT books and she trained several clinics that started spreading PCIT in the States, and she trains actually all over the world. Just another acknowledgement to those who have contributed to these slides: Dr. Cheryl McNeil, Dr. Paul Abner, Dr. Christy Warren-Metzger, Erin Q, and Lindsay Phillips. Erin and Lindsay are actually my level 1 trainers. I trained them as therapists many years ago, and then I trained them as level 1 trainers, and now they help me with training because it's hard to train on your own. All right, let's talk about what is PCIT. What is parent-child interaction therapy? I'm gonna pull video here. For that, I'm gonna have to navigate this. I'm gonna stop the share. I'm gonna pull the video. Let's see. Do another screen share. Okay, let me turn up my volume, and you should be able to hear pretty good. Oh.
PCIT is a treatment. It stands for Parent-Child Interaction Therapy, and it's a way of working with young children with disruptive behavior disorders and their families. So it's a treatment that focuses on improving the parent-child relationship. It teaches parents skills to increase appropriate behaviors in their kids, like following directions, and decreasing inappropriate behaviors like whining or hitting. It involves live coaching of parents so that we can observe exactly what happens between them and their kids. It's also a program that helps parents use very consistent and predictable strategies. It helps kids improve their behaviors and also feel more secure and positive about themselves and about their relationship with their families. So it's what we consider an evidence-based treatment. So it's been studied in hundreds and hundreds of kids and shown to be very effective in helping kids' behavior get back into the typical range of functioning, but it also helps parents feel less stressed, sort of more confident as parents. Every family that completes treatment is considered a treatment success. Treatment ends when child behavior is back in the typical range of functioning. So when families get to the end of treatment, it's because they've demonstrated these improvements and these changes.
Okay.
Are you tired of the media spinning the truth and put?
Stop share. Okay, let's go back to this one. Okay, perfect. Okay. All right. So let's talk about the history of PCIT. And interestingly enough, PCIT started in Oregon when Dr. Sheila Iberg, in the picture, was doing her internship at OHSU. There were 3 very notable psychologists at the time there, Russell Barkley, Connie Hanf, and Sheila Iberg, and they were all working in different parent training programs. And Sheila Iberg then went to the University of Florida in Gainesville and continued developing a PCIT as a treatment model with the help of Dr. Cheryl McNeil. From there, her graduate students continued using PCIT wherever they went in their employment, and that's how PCIT started spreading. PCIT is now one of the most recognized evidence-based practices in the world, and empirically supported treatment, meaning there's a lot of research behind it, a lot of research that supports its effectiveness, and it is used in many countries around the world. The training has disseminated significantly to Asian countries, European countries, Turkey, many other countries, but the only part of the world that we're still not targeting, but hopefully in the next couple of years I will be able to do that, is Latin America. So I am actually the only fully bilingual, fully bicultural PCIT therapist in the world. So I'm hoping to pretty soon target Mexico down, you know. Okay. Want to talk a little bit about something that you guys, I'm sure, are very familiar with. You know, the California Evidence-Based Clearinghouse for Child Welfare. Lists PCIT as one of the most prominent EBPs. It is also recognized for funding under the Families First Prevention Services Act. As you know, that is to prevent children from going into the foster care system by allowing federal funding to be reimbursed for mental health treatment, for substance use treatment, and for in-home parenting skills training, such as CISRAS services. It also targets children who are already in the child welfare system to receive services to be able to leave the system as soon as possible with the necessary services that will allow them to be successful, you know, in their development. Okay. This is a map of the current PCIT sites in Oregon. As you can see, we still have many counties to disseminate PCIT to. We have been targeting some rural counties in the last biennium. We grew quite a bit. We currently have 34 agencies with 65 physical sites across the state. So it is pretty well spread. However, like I said, we still need to target Eastern Oregon a little more. We have one clinic in Malheur County, but we still need to target those counties that are nearby. And you do have a handout available with all the agencies, their contact information and their location in case you need to make a referral. All right, I'm going to talk very briefly about the theoretical basis of PCIT, just because I think it's important to understand where it comes from in terms of the context to later understand why it is a good treatment for children in the foster care system, okay? So attachment theory, we know that attachment is survival. It's, you know, attachment, having a secure, positive attachment with at least one significant adult in your life when you're a child is the #1 protective factor for emotional health. You could have, you know, come from a family with you know, a lot of wealth and live in the best area in town, go to the best school. But if you don't have a secure and positive attachment relationship with a significant adult, you don't have that most important protective factor. So that's the importance of attachment. And PCIT works on providing that level of attachment. Parenting styles. We look at parenting styles. There are several parenting styles: authoritarian, permissive, authoritative. We want to be authoritative. We want to help parents to have a very good balance of high warmth and high demandedness in the relationship with their child and their parenting style. Those, you know, those that are pretty authoritarian, we see their children being pretty rebellious and defiant. Those who are permissive, we see children who get their way because they are the typical children that escalate in the middle of the grocery store and the parents give in, right? The parents will buy the candy or the parents will buy the toy just so that the child stops the tantrum right there because they feel embarrassed. So we want parents who have that level of limits and that level of warmth and are able to manage the behavior. We also pull from Skinner's behavior modification, you know, operant conditioning, very popular, very widely known, positive reinforcement or punishment. So positive attention, and or you get a consequence for misbehavior. Social learning, we base a lot of the interventions in PCIT in parent modeling. So we use the parent as someone who's gonna affect the change in the child's behavior because they're going to be modeling the behavior we wanted to see in the child. And we also pull from Patterson's coercive cycle, which is a bidirectional process, meaning those parents that engage in a power struggle with a child, those parents that argue with a child, those parents that, you know, are in a war with a child and escalate together. So they may reinforce the negative behavior by engaging in that kind of arguing and power struggle. They reinforce the negative behavior, which will escalate, and the parent will continue to escalate at the same time. So we pull from those concepts to change the patterns of behavior, the patterns of interaction. Some of the core features of PCIT, yeah, as you heard in the video, active coaching. In PCIT, we do what we call in vivo moment-by-moment coaching. We use a bug-in-the-ear device. We use technology, one-way mirror, to talk to the parent or the caregiver and coach them while they are in the session with a child. The emphasis is on restructuring the interaction parents, the relationship, rather than targeting the problematic behavior. If we target, like in many other interventions, the problematic behavior, that's the only behavior that may go away temporarily. If we change the relationship in the way the caregiver and the child interact, then we're going to have long-lasting effects. And that is the reason why in PCIT, we have research that show that treatment gains are maintained up to 6 years after they complete a treatment, because we change the pattern of interaction rather than the behavior. It is assessment-driven. There is no time limited, meaning we're not going to tell you you only get 10 sessions and whatever we do, that's it. We are going to be assessing on a weekly basis, and I'll show you what tools we use. We talked about it being empirically supported, and qualified clinicians. Clinicians have to be through a very rigorous training. It takes about 2 to 3 years to become a certified PCIT therapist. So you have to demonstrate mastery of a lot of skills. You have to turn in numerous videos to show that you are doing PCIT with treatment integrity and according to the protocol. Okay. All right. Coaching. Coaching, like I said, in vivo, moment-by-moment coaching allows us to observe the parent-child interaction that is happening right there in front of us, and allows us to coach the parent in changing that interaction to make it more positive, to make it more warm, to make it, you know, in a way that they're gonna be able to get along better. It gives the parents specific feedback. It's not, this is very different from a parenting class where you teach something and then you tell the parents, okay, go home and try it and see if it works. In PCIT, we help the parent do it right there so that they practice, they rehearse, and they go home knowing how to actually do it. We can correct errors immediately, and we can praise and reinforce the behavior or the skills that we want to use, and we can assess readiness to move on to the second phase of PCIT on a weekly basis because we're doing in vivo moment-by-moment coaching. So this is just a picture of my PCIT room at Jackson County Mental Health. As you can see, this is, of course, a mock picture. We don't have a real child. This is the child. It's just a teddy bear. We have one-way mirrors in my PCIT room, a small table mounted on the wall, couple of chairs. Most of the times, families actually play on the floor, and that's totally fine. And the parent wears it back in the ear where we communicate. And this is the PCIT coaching room. So we have equipment, specific equipment designed for PCIT that allows us to see on the screen what's happening in the room. This is the camera. It's also specific for PCIT. And we can switch the camera depending on where the child and the caregiver are. We can also, of course, look through the one-way mirrors. Let's talk a little bit about restructuring interactions, which is one of the core components. Again, we are gonna emphasize the interaction pattern because it leads to global improvement. We're not gonna target one specific behavior. We want to affect changes in a large scale. So we're gonna see changes or improvement in the child externalizing and internalizing behaviors. You know, we're gonna see those behaviors such as anger and biting and kicking and spitting go down. And those children who are really withdrawn and quiet and anxious and isolating, they're gonna come out of their shell. They're gonna feel more self-confident. We see for sure increased child compliance. Typically, we actually measure compliance pre and post treatment. Typically, a pre-treatment, it's probably below 20%. We want compliance to be at least 60 to 65% at post treatment. And the parent stress goes way down, and locus of control, meaning their own control of their own emotions. They are able to self-regulate much better, which leads to the child being able to mimic that self-regulation as well. It is assessment driven. We have specific treatment goals. We monitor those goals every time. We have mastery criteria for the skills that the parents are using. We use the IBER Child Behavior Inventory on a weekly basis. It is a 36-question inventory that the parents fill out every session to tell us how the child behaved the previous week and whether the behavior was a problem or not. So we have, there's research on all of that. We have specific numbers, specific criteria. We measure that on a weekly basis. This is an EGB graph, a sample of an EGB graph. Once we score the EGB every session, we transfer the data to the graph. And as you can see, this child normative range in the EGB is 114 intensity and 15 or less problem behaviors out of the 36 items. This child was at around 169 at pre-treatment, and he is at 46 at post-treatment. So the EGB is a really good indicator of improved behavior, and he was at 27 out of the 36 behavioral problems, and he is down to 5 behavior problems. So definitely huge improvement here. Excuse me. It is, oh, excuse me, I'm gonna have to drink a little bit of water. Okay, it is not time limited. Most families take between, I would say in community mental health, about 20 to 24 sessions. It is designed to be potentially completed in between 12 to 16 sessions, but in community mental health in Oregon, I think our average is about 20 sessions. And that is, you know, because the clients that we work with in community mental health have their own issues, the caregivers have their own issues, their own treatment. So taking all that in account, it is actually a pretty short treatment. It is empirically supported. We've talked about this. Excuse me, I need to cough again if you want to. Excuse me. Okay, so treatment outcome research. What we know is that the treatment gains, like I said earlier, are found at 6 years post-treatment. The skills generalize to home and school. The behavior improvement generalizes to home and school. It generalizes to untreated children in the home. So parents use the skills with other children as well. It changes the parents' interaction style, and the stress level in the parents goes way down. We've had families that come to us saying, you know, parents that come to us saying, we're about to divorce, to get a divorce because we just can't agree on how to discipline Johnny. And after PCIT, they are just happy family. We have lots and lots of controlled studies, randomized controlled trials that show strong skill acquisition, more positive attitudes towards the child, high consumer satisfaction, generalization, like I said earlier. So it is really a well-rounded treatment. Now, what really makes PCIT unique among other parent training programs? So PCIT balances two factors. One is the positive interaction with the child. We work on increasing positive attention to positive behaviors and on decreasing negative attention to negative behaviors. So right here, we target the coercive cycle. We're not going to provide negative or positive attention to any negative behavior. We also work on providing structure by defining that by consistency, predictability, and follow through. This is something that the parents we work with really lack. They don't know how to provide limits, and parents whose children are in the foster care, when they come back to them, they struggle a lot with this. They tend to parent out of guilt, and they have really great challenges in providing consistent and firm limit setting that can lead to a much better relationship. PCIT has two phases of treatment: CDI, or child-directed interaction, and PDI, or parent-directed interaction. In CDI, the child leads the play. It is just like play therapy. The parent or the caregiver learn the same play therapy skills that we would use if we were doing individual play therapy with a child. We teach differential reinforcement, meaning we're gonna target the positive behaviors and not pay attention to the negative behaviors, and we work on nurturing the relationship. PDI, the parent leads the play. It is predictable, it is consistent, and there's follow through. We work on limit setting and compliance training. We teach children to comply, to obey, because by teaching them to do what they are being told to do, a lot of the disruptive behaviors actually go away. Okay, CDI. I love this quote. Play is often talked about it as if it were a relief from serious learning, but for children, play is serious learning. Play is really the work of childhood. And it's true, that's why PCIT is play-based, because it's for children between the ages of 2 to 7, and that's what they do. That's their world, that's how they learn. So basic rule of CDI, follow the child leads, the child's lead. We have 3 skills that we're gonna avoid in CDI. We're gonna train caregivers, so not giving commands, not asking questions, and not making negative critical statements or sarcastic comments. Commands because they direct the vocal or motor behavior of the child. Commands can lead to, a rough interaction if the child doesn't wanna comply. We're gonna pay attention to 2 types of commands: direct commands that exactly tell the child what you want them to do: draw the sun, hand me the car, put your shoes on, sit in the yellow chair. Or indirect commands that could be a question or a suggestion, and yet the expectation is that the child will do what you're asking them to do. Like, would you like to put your shoes on? Or do you wanna go wash your hands now? Can you help me with this? You're not telling them, do this, and yet that's exactly what you want them to do. Okay. Questions, because again, they lead the conversation. They can suggest disapproval. They can suggest that you're not listening. So we work a lot with parents on eliminating questions in PCIT, all kinds of questions: the what, where, why, the unintentional questions when we're talking and we bring our voice up, our inflection up. And by doing that, it turns into a question, or questions that have tags at the end, when we say, huh, or okay, or isn't it? So we turn statements into a question. We, of course, don't want to make any critical or sarcastic statements because we work with children who are pretty young and they are working on getting to know themselves and on their own self-esteem. So we don't want to hurt that. They get their feelings hurt easily, so we don't want to do that. And sarcasm, because they don't understand sarcasm. They are too young to understand the meaning of a sarcastic comment. And we work on avoiding words like no, don't, stop, quit, and not, because they're negative words, and we want to stay positive in the first phase in CDI. What skills are we going to use? The pride skills. Praise, reflect, imitate, describe, in enthusiasm, or enjoy. You also should have a handout accessible to you in the website, right? Yeah, okay. With the pride skills and the avoid skills. So praise basically means that we're going to praise the positive behavior. We're not going to praise the behavior that we want to see more of. We typically hear parents praising their children, saying, good job, good girl, good boy, right on. And that is good. Those are good praises, but we really want to be labeling the praise. We want to tell the child exactly what we are praising them for. Thank you for sharing with your sister. Good job eating your soup. I'm proud of you for putting your shoes on all by yourself, okay? Unlabeled praise, like I said, is good, but it's not specific. Reflections, meaning we're gonna reflect what the child says as long as his conversation is appropriate. Basically means repeat like a parrot or paraphrase what the child is saying. It allows the child to lead the conversation, shows that you're listening, that you're interested, and it teaches the child to carry on a conversation rather than just answering questions. So the child says, Mr. Potato Head is jumping. And the parent says, he's jumping very high. So you repeat it, you paraphrase, and you're letting the child know, I'm right here, I hear you, I understand. The I is for imitation, and basically is the best way to approve what a child is doing by you doing what they are doing. You're basically just gonna imitate, copy what the child is doing, following their lead. We are gonna keep it at a developmental level, meaning what you're doing has to be equal to the child's or maybe even a little worse. For instance, if you're drawing a picture and the child is drawing a picture and you decide to draw a picture to imitate what they're doing, but they're 3 years old, so their picture is not gonna be the best picture in the world, but you're a great artist and you make beautiful pictures, so you're gonna have to make a picture that is not as good as the child's. You're gonna keep it at his developmental level. Descriptions, we're gonna target behavioral descriptions that pretty much sound like a running commentary of the child's activities and behaviors. You're building a tower. You're stacking 2 red blocks together. Now you're looking for more blocks. Oh, you got 3 more blocks. And now you're dumping all the blocks out on the carpet. You're sorting them by colors. Just describing play by play. It really helps the child organize their brain process and organize their play. We see children whose play is very scattered really turn their play into very appropriate and organized once we start doing behavioral descriptions. It teaches a lot of concepts without really sitting down to teach your child something. It's just by playing with them. And the E is for enjoy or enthusiasm. We work with parents on conveying that in their voice, in their facial expression, their body language, eye contact, matching the child's level of enthusiasm with their voice and play. It really adds a quality of warmth to the interaction and makes it more fun. All right. Again, when we have children referred to PCIT, they usually are referred because they present disruptive behaviors. So when we see disruptive behavior in session, we quickly determine if the behavior is dangerous or disruptive or just annoying and obnoxious. If it's annoying and obnoxious, we're gonna use a strategic attention, meaning we're not gonna give any attention to that behavior as long as it remains safe. We're gonna ignore, we're gonna look away, robot face, engage in something else until the child corrects that behavior or re-engages with us in a positive way. When the behavior is dangerous and destructive, we stop the play and take care of it. Of course, safety first. There is a requirement that parents engage in daily home practice. They have to do special playtime using the PCIT skills for 5 minutes a day, no more than that. And we ask them to really make a commitment to do no more than the 5 minutes. There's actually research that shows that caregivers who engage in more than 5 minutes drop out of treatment because it's too much, it's too overwhelming. So the 5 minutes a day have to be one-on-one, providing positive attention. And we recommend that it is done in a consistent schedule so that becomes part of the child's daily routine. This is a sample of the CDI skills progress record. Just like we keep track of the child's behavior by doing the IBER child behavior inventory graph, we keep track of the parents' skills. We wanna keep track of the behavioral descriptions, reflections, labeled praises, unlabeled praises, questions, commands, negative talk, and we have specific mastery criteria. They have to give 10 behavioral descriptions, 10 labeled praises, and 10 reflections in a 5-minute period with no commands, no questions, and no negative talk. All right, let me get out of here real quick to pull up a quick coaching video. Oh, hold on. I'm trying to share screen.
Do that one.
Okay, Mom, your skills are up from last week. You gave us many more behavior descriptions. Last week you had 2, this week you had 7. That was great. And you gave him lots of labeled praises. I can tell you've been practicing on that and turning those unlabeled into labeled praises. So go ahead and keep interacting with him and using your pride skills. And I'm going to be coaching you.
You took the head off the neck. Oh, you're going to put him on that neck.
2 great behavior descriptions.
Oh, I like how you made them short like that.
And that's a wonderful labeled praise. You told him exactly what it is he's doing that you like.
His neck. Now you took it off of his neck.
Great reflection. You're repeating what he's saying.
You're trying to figure it out. You're looking hard, thinking hard. Wait.
Great. Those are 3 great behavior descriptions.
Yes. You know, I think you are really good at reading maps like this.
Great labeled praise. You're really using all of your skills and it's keeping him more engaged in the play, and I can tell he's paying much more attention this week.
Another one of these.
Another one. Oh,
great reflection that lets him know you're paying attention to what he's saying.
Next week I'm doing one too.
Next week you're going to make another one of those.
Great. Your voice went down at the end and that made it a reflection.
Alright. Let's see. You put the wing on that.
Good behavior description.
2 more blue things.
And a wonderful reflection. You're really...
I stop right there. I just wanted to give you guys a quick sample of what the coaching is like. So you're behind the mirror and you're coaching the parent through the bug in the ear device. All right. So parent-directed interaction, PDI, is compliance training, is what all parents who come seeking PCIT come for, and yet they have to wait and do CDI first. Why do we do compliance training in PDI, in parent-directed interaction? There's a lot of benefits for parents. They reduce embarrassment and inconvenience. A lot of parents of PCIT children are called from school or from daycare to come pick them up early because of their behavior. A lot of the children have a modified schedule in school, and quite a few of them actually are expelled from daycare or preschool. Expelling rates for preschool children are much higher than for school-age children. A lot of parents actually lose their job or are at risk of losing their job because of the disruption, and they have a really difficult time finding quality childcare because of the child's behavior. The benefits for children, they are increased safety, both physical and emotional. They learn to follow rules. They are better at socialization. They present positive school readiness because we work on pro-social schools. So PCIT kids are really ready for school after completing treatment. They develop internal locus self-control, meaning they are able to regulate their own emotions. They have improved peer interactions and daily life skills. And of course, they are at reduced risk of abuse. We work in PDI by teaching effective commands. We teach specific rules for commands and compliant exercises. We teach the child to comply, starting with very simple, easy play commands, and then increasing to everyday commands, cleanup commands, and generalizing to other behaviors until all the behaviors of concern are gone. The consequence for noncompliance is timeout. It's a very specific type of timeout. It has scripted wording. You always say exactly the same. Parents are coached step by step before, and they have to demonstrate mastery of the timeout sequence before they are allowed to implement it in the home. And PCIT timeout actually allows for overteaching compliance and for a quick emotional recovery, meaning the child and parent, once the timeout is over, they're done with that and they re-engage happily in playing with each other. We also use a backup space as a consequence for not staying on the timeout chair. It is a space that has to be at least 5 by 5, wet-lit, ventilated, with nothing in it for the child to get hurt with, and with a Dutch door or other way for the child to be able to see that the caregiver is standing right outside. We have alternatives for some clinics who don't have a backup space, and we have worked closely with the Oregon Health Authority Compliance Office to make sure that what we are using in Oregon is safe. I think I'm going to skip this one just because of time, and I'll show you just a picture. So this is a picture of my PCIT room in the backup space. As you can see, the Dutch door. This door doesn't lock. The parent has to push this latch in, and the parent stands right here. So the child can always see that the parent is right there. This is the view from with the door open. It's large, it's well lit, it's safe, and there's nothing on the other side. So the door does not lock at all. The parent lets go and the door opens immediately. And this is just a sample of the toys we use. All right, target population. PCIT is for children 2 to 7, 2 to 6.5 years old that have primary or secondary disruptive behaviors. Their receptive language has to be at least at about a level of functioning of 2 years old. Parents have to be equivalent to a high school diploma. We do work with some parents who have mild cognitive delays. Treatment takes longer, but it's doable. And the ECB has to indicate that there's need for PCIT, and the primary therapist has to be fluent in the family's language. Disruptive behavior is actually the most common reason for referral. It's very, it affects many children in the world, basically. It is associated with pervasive impairment over time. It's stable over time, meaning it maintains and can actually get worse over time if not treated. It is very costly to society. There's research that indicates that treating disruptive behaviors at a later age is more costly than treating asthma, diabetes, or epilepsy. And it is strongest risk factor for delinquent behavior later in life. And this is just a continuum of the type of referrals or the type of problems that we see in PCIT. Some can be mild relationship problems, some can be disruptive behaviors, and some can be pretty significant conduct problems such as cruelty to animals, fire setting, physical aggression. And it's a continuum. None of them is better for PCIT. All of them qualify for PCIT, and all of them improve. A typical referral, temper tantrums, they don't listen, they don't comply, they are aggressive, preschool, having difficulty, or daycare, difficulty managing their behaviors. Parents are seeking help because they don't know what to do, and parents are able to attend weekly 60-minute sessions. Okay, PCIT with children in foster care. Just briefly mentioning the Kaufman Best Practices Project and the National Child Traumatic Stress Network. You probably are aware. If not, I provided the links to this. This is a really interesting document. It was a joint effort between the San Diego Children's Hospital and the National Child Traumatic Stress Network's National Call to Action, a movement to end child abuse and neglect. And they were charged with identifying 3 intervention protocols that would qualify as best practices in helping children recover from the impact of abuse experiences. The protocols they reviewed had to meet rigorous criteria, and PCIT is one of the 3 they identified. The other 2 are trauma-focused cognitive behavioral therapy and abuse-focused cognitive behavioral therapy in PCIT. So very, very proud of that, of course. The National Child Traumatic Stress Network recommends PCIT as one of the interventions under their trauma treatment section. The Child Welfare Information Gateway has some articles about PCIT with children in child welfare. And of course, we mentioned earlier the Family First Prevention Act. This particular study was done with families in the child welfare system. They divided a group of families into 3 groups. One group received PCIT only. A second group received PCIT plus an enhanced service like wraparound or individual play therapy. And the third group received a standard community-based parenting class. They reassessed the families or the data at 850 days later. 49% of the families that received standard community-based parenting class had a re-report for abuse. 36% of the family that received PCIT plus another service had a re-report for abuse, but only 19% of the families who received only PCIT had a re-report for abuse. And the reason, again, goes back to the fact that in PCIT, we target the interaction parents rather than the behavior. Okay, this is data in Oregon. The Oregon Health Authority partnered with West Virginia University to review the data for 914 families in Oregon in the last recent years. Those families attended at least 4 PCIT sessions, and we got an effect size of 1.43. Now, if we think about effect sizes, if you remember your statistics classes, an effect size of 20 is small, 50 is medium, and 80 is large. So an effect size of 1.43 is definitely astronomical, meaning PCIT is extremely effective. It is higher than the effect size that stimulant medication has. Other treatments that are widely used in Oregon, like cognitive behavioral therapy, incredible years, triple P. They are good treatments, but the effect size is not as significant as with PCIT. What are the benefits for doing PCIT with children in foster care? They show improved overall emotional regulation, which is basic for developing a secure attachment. If a child is not able to regulate their own emotions, they are not going to be able to engage in a healthy relationship with a significant adult that can be that secure attachment. We see reduced overall disruptive behavior. We see decreased overall anxiety. It promotes secure attachment, of course. Sometimes there's a question about whether it's recommended to do PCIT with foster parents. And the answer is yes, because attachment is transferable. So if a child develops a healthy, positive, secure attachment with a foster parent, that child then has the skills to engage in positive, healthy relationships with someone else. And it secures placements. You guys know that many children, many placements are at jeopardy because of the child's behavior. So we do PCIT with these families, and placement is secure. We also see that they do better in daycare, in school, and of course, we achieve the ultimate goal, which is we provide the #1 protective factor, which is a healthy relationship with an adult. Okay. When to include biological parents or primary caregivers in PCIT with children in foster care? So ideally, there should be a reunification plan and a timeline. We estimate that probably within 2 months of reunification, it's a good timing to start including those biological caregivers. We want to see that visitation has increased, and the child welfare caseworker must arrange contact at least 5 times per week so that the biological caregivers can do their daily homework practice. And ideally, we often request that the case remain open until PCIT is complete, because I'm sure you've seen cases in which as soon as they start PCIT and child welfare gets away or closes the case, then that family doesn't complete treatment. So we often request that child welfare keeps the case open. I also wanted to mention that we have an adaptation of PCIT to work with children between the ages of 12 and 24 months old. I included the website in the list of websites so that you can take a look. It is evidence-based as well, the same theoretical underpinnings, same principles, same concepts, same skills. It is just developmentally adapted to toddlers. All right, I think we covered everything, and we have a couple of minutes for questions. Any questions? You can unmute yourself and ask a question, or you can type it in the chat box.
Alejandra, will this recording be available
Yes,
online?
I believe so, right, John, Rebecca?
Yes, I'm recording
Yes,
it right. I'm recording it right now for the CRB, and we will have it posted as soon as it's available. So it will be done.
Yeah.
And I was also going to ask, I missed the last parenting style, the high warmth, high control.
So that is what we are aiming for. That is the authoritative.
Authoritative.
So exactly, it's a balance. We want to provide a balance.
Thank you. It was very well presented. Thank you very much.
Thank you.
Alejandra, this is Donna. I was wondering, you said it could work with foster parents. Would
Yes.
you have a situation where you might work through it with the foster parent and then subsequently follow up with treatment for the parents?
Yes, all the time. So the child gets, benefit of 2 rounds of PCIT.
Right.
Sometimes we start with the foster parents and complete with them, and then start with the biological parent or caregiver. Or sometimes, the child is transitioning to the biological caregivers in the middle of PCIT with the foster parents. So we do it all the time.
Would you ever have a situation where you're doing it with both of them, like you started with the foster parents and the parents become more engaged, and then the foster parents continue at the same time that the parents are doing it?
Yes. A few situations, like I said, there needs to be a timeline for reunification. So we need to make sure that and of course we never know, because we've seen cases that we're about to, reunification is scheduled to happen in 2 days and parent relapses or something happens and reunification can't happen. But ideally, we should have a clear picture of when reunification is going to happen before we include the biological caregiver in PCIT. And of course, we have many foster parents who want to continue being a resource for that family, even after the child goes home. So many times we work with both the foster parent and the biological parent at the same time, and they support each other.
Yeah, good.
Yeah. Mm-hmm. Yeah.
Who would make the recommendation, the DHS or like the child's therapist, or, to know that it would be at a time when it's appropriate for the parents nearing reunification?
Yeah, typically, the therapist should be in constant communication with the caseworker, to learn about how the case is going and timelines. And at that point, they can make a recommendation. Of course, what we want is to support that child in having a smooth and positive transition. So if we can include the biological parent, that's fine. We want that, definitely.
Thank you very much.
Mm-hmm. You're welcome.
Alejandra, this is Rebecca. I have 2 questions.
Sure.
First, there was a slide where you were talking about starting the PCIT with parents as part of the reunification plan. And there was a bullet that said the caseworker needed to make at least 5 contacts per week. Can you expand on that? And
Yes.
So they could do their homework? I didn't quite understand that.
Yes. So PCIT, one of the core elements of PCIT is daily homework. So the caregiver participating is dyadic treatment. So the caregiver participating in PCIT with the child has to go home and do what we call special playtime or home practice 5 days a week, 5 minutes a day, 5 days a week. So if we're going to start PCIT with a parent who doesn't have the child full-time yet, then the caseworker has to approve and arrange or make sure that that parent has access to the child 5 days a week. Okay. So that they can do homework. So many times we've had cases in which Head Start, for instance, allows biomom to come by every day and allows the child to go to the playground so that they can do their 5 minutes of special playtime. So, yeah.
Okay.
So sometimes we coordinate with more than one partner agency to make things happen. Yeah.
Yeah. And my other question is, many times when we read psychological evaluations for children primarily, or even with parents, the psychologist will make a specific recommendation that PCIT be provided to the family. And in some of our counties, like you showed the map, there is not a trained provider available. So DHS can't, implement that recommendation, even though it's so, it's just so critical. Do you have a recommendation for a similar form of therapy or something that could be used in absence of a PCIT in a county that doesn't have it?
Mm-hmm. Yes, so there's a couple I'm thinking of. One is PMTO. I don't know if you guys are familiar or have heard of that. It's also in Oregon, is Generation PMTO, Parent Management Training, I think so. I think the Parent Management Training, Oregon, that's the O. It is very similar, somewhat similar to PCIT. Some of the same concepts, some of the same skills. There's not a lot of in vivo moment by moment coaching, but it also targets the relationship, which I think it's crucial, you know. The other one I'm thinking of is CPP, or child parent psychotherapy. That is more widely spread in Oregon as well. It's also dyadic treatment, meaning you need a caregiver in the child. That, unfortunately, that only focuses on trauma. And the caveat is that the caregiver participating with the child has to be willing to open up and talk about their own history of trauma. It has to be willing and ready to talk about the traumatic event with the child from the beginning. So in that kind of, and I'm certified in CPP as well, so in that kind of intervention, we start treatment by talking about why we are here. So if the caregiver is not ready to talk about, we are here because your mommy wasn't able to protect you from your daddy and your daddy did these things to you, then we can do that. Yeah.
Yeah.
It's really good as well, really effective. Yeah.
Okay. Thank you.
All right. Does anyone else have any other questions? I'd like to keep to our timetable that we had agreed upon. I'm a stickler for that.
Good.
Anybody else have any further questions?
Most people are muted, so if you're trying to talk, you'll have to unmute yourself.
That's true. Or you can type it. So
my email is provided as well. If you have any questions later on, please feel free to email me as well.
all right.
Well, this was a wonderful presentation, Alejandra. It'll be very useful to our volunteers. So we'll make sure people are aware that it's recorded and that they can view it. Go ahead, John.
Okay. Perfect.
All right.
Thank you. My pleasure.
All right. Thank you, everybody, and thank you especially Alejandra, and for being a part of this and for giving of your time. You were so generous. She was originally going to come to our conference, of course. They got canceled, but she was more than willing to make these adjustments, and that's just tremendous. So we do appreciate so much her efforts. You're very familiar with the Citizen Review Board, so
yes.
that is really helpful too. So we appreciate
it. Of course. Not a problem. My pleasure.
All right. All right. Thank you. I think we can go ahead and end this. Before you do that, I'll stop the recording so it doesn't do any weird interruptions.